You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Before you ever come out Sweet Pea and you've been in Alabama, it's Taco Casa is greater than.
Hey,
My
real
Sweet
quick, since we have guests, can we get in? I can't even look at this guy. Get a mic check real quick, just so if somebody can't hear you well.
Can you hear that?
Hello.
All right. Hello.
We good? Cool. So first of all, thank you guys I'm talking to these guys in this room, first of all, because coming out at 6 p.m. and I guess it's not that tough to come out and have drinks and eat pizza, but coming back to work after being at work all day. Thank you to the new residents. This is the first kickoff of this round of the residency, which it's not really going to be a round of the residency anymore. It's just going to keep going. So past residencies, we had grand rounds, which was basically it pivoted mostly around case studies, and then we'd have, general lectures. So I think this is a level up because you get not one clinician, you get, 4 clinicians, you get multiple case studies. And now you can join live and, get questions answered, be part of the convo, put your input in. For those people that maybe, watch this in the future, also realize you can submit your own cases via the form that is behind the residency paywall. Whether you have a problem case, you want specific questions answered, or you just have a really cool case and you have the option of having us present that, one of us, or you can present it. So you could be on the Zoom call and present it for everybody else. Lots of other perks of the residency, but thank you guys for being here with us. And I know we have a beer, green tea, a Sprite, kombucha, bourbon, Sprite, and wow, you're double fisted. Sprite.
I got the boot Sprite combo.
What'd you go with? I got some Heaven Hill.
I'm with Angel Indy.
Ooh, sounding like angels in heaven.
This one doesn't taste very good, but I'm still gonna drink it because it's liquid.
That trilogy?
This is energy. So we should be doing with our abdominal wall. It's energy.
Doesn't even know what I'm talking about.
Really?
So we have 2 different cases for you tonight, and at any point, whether you got to do the little emoji hand raise so we can see that you have a question, please pipe in so it's not just a diatribe and then a ton of Q&A at the end. But we will have a separate Q&A at the end that could be pertaining to cases. It could be anything else. I highly encourage you to put on some hater blockers, some sort of goggles. Probably not those goggles because he can't breathe and I can't look at him without.
Just wait 1 second.
Seeing.
There you go.
If you're not of my generation and you didn't play Super Mario and the fish that jump out of the water with the red lips,
Yeah.
that's you. Yeah, let's get rolling. Who wants to go first? I think I'm going to go
Why would
first.
you look at me,
I
Alex?
want to see how much oxygen debt he can get into and then have him present and see how it still goes. He's clearing over here. So let us know if you have any questions. Let's get rolling. As much as I wish you could see this guy, obviously that's not a reality, but this guy's a character. And as soon as you saw him, you would be like, yep, that is a runner. So we have a 59-year-old male avid runner. When I say avid runner, impressive, like very impressive. We'll talk about that here in a second. So one interesting note, because this is part of the residency now, is how this guy actually came into the office. He is the only person that came in because he saw a banner on the sign along the track, which it wasn't a farm sign, it was a farmhouse, like our gym sign. Don't do that stuff. I didn't want to do that. Our gym owner wanted to do that, and I'm not knocking that, but like he literally goes, he even said when he typed in on the, referral thing, you've probably never had anybody come in off these signs. Yeah, we never have. And they cost a lot of money.
Yeah, actually just talked about it.
Yeah. So if you're ever thinking of like doing this high school sponsorship, track sponsorship, just don't do it. Put your money elsewhere. So that's an aside. But that's how this guy came in. He notes that he's been dealing with left hamstring and Achilles pain for the past 2 to 3 months. He runs 5 to 6 days a week, with 3 of those being on the track. Again, this is a 59-year-old guy. He's now a private sector investment banker. He started his own company. He has a goal of running a sub. Now it's a 5:15 mile every year. So it used to be he had to run a sub 5-minute mile every year to just basically feel like he was still fit. So again, this is a pretty studly runner. even though it looks like you get blown away in a strong wind. He does no weight training. He eats pretty healthy. He leans toward kind of vegetarian veganism a little bit. He's been trying to stretch his hamstring and Achilles with no relief. It doesn't exacerbate. It's just not changing it. He reports no prior similar issues or any low back pain when I ask him that. He notes that his left leg almost feels dead, or that he can't take it through a full clean stride, which he mentions that phrase. I don't have this smooth open stride like I used to, like all the time throughout numerous visits. That's like a theme. No paresthesia noted. So he just, no numbness, no tingling, no, loss of sensory sensation. He just, pain, discomfort in his hamstring and his Achilles. So on general presentation, he just has kind of a slight thoracic kyphosis. He's a pretty slight guy. He's, I think, 5'8". I don't know how much he weighs. Not that much at all.
It's good.
Yeah. It's a good measurement. Yeah. Is that you?
Yeah.
Hold him down the floor over there.
Yeah. Don't worry.
Can you guys see him behind the mic?
On a good day.
If
I come out around, I understand. It's a little big.
Not a wasp. That is set.
No, I'm not Ant-Man.
Okay. Okay, so we dive in, and I also want you guys to know that I'm really going to try to adhere, and we all try to adhere to kind of the art of assessment process. So there's some sort of systematic process of presenting a case, which if you do submit a case, that same process is outlined in the form. So that helps you kind of adhere to those guidelines, make it easy for everybody. So on top tier of SFMA, the only things this guy is functional, non-painful in is bilateral upper extremity 1 and 2. Everything else, not great. Things that are real standouts. This guy is a country mile from touching his toes. There's no pain on that though. He just, if you think of a 59-year-old runner that's been doing track workouts 3 times a week that runs a 5-minute mile, this is a stiff guy, right? That's just a phenotype that's going to exist. So we move on from that into gait. Lack of pronation bilaterally with reduced dorsiflexion through mid stance, as well as reduced hip extension. I say chicken or egg there. Does that make sense to everybody, that if you have what seems like reduced dorsiflexion, you don't know if it's hip extension or dorsiflexion because they affect one another the same. You can't dorsiflex your ankle through mid stance. You can't extend your hip. You can't extend your hip. It's going to look like you can't dorsiflex. You kind of with me on that? And you can hide them pretty well, but you got to check that on the table. And then he has a little bit of like left hip coronal plane shift with decreased hip internal rotation. So it kind of looks like he's swinging his left hip around his right. So as he goes through mid stance on his right, it's like he's kind of going out around that right leg. He has no complaint on the right side. Remember, it's all left hamstring and Achilles. General range of motion. So his right hip is limited in external rotation, no pain. Limited hip extension and prone bilateral, no pain. And ankle dorsiflexion is a soft tissue limitation bilaterally. And I wouldn't say it's crazy limited, like it's just not awesome. So that's kind of general as we're going through joint range of motion. Then we jump into kind of palpation, TL junction, rotation extension, big surprise there, restriction. And then he has a honking trigger point in his left glute, but he has no referral out of it. So glute med men, big trigger point. He gives you the typical, ooh, yeah, no referral though, right? It's not creating symptoms in his Achilles, his hamstring. And again, I say these things in a certain way, so you're kind of keying up like, okay, yeah, that's important, but it didn't reproduce symptoms. So where does it go on the hierarchy of functional audit, pain audit, everything like that?
Hey, real quick.
Yeah.
I don't think I ever remember the chief complaint.
Left hamstring and Achilles pain, about 2 to 3 months duration, obviously worse during runs, worse when he sits, which maybe I didn't mention that. But yeah, it's just kind of unrelenting. It's always there. It gets worse when he runs. And the big thing for him is he feels like he has a dead leg when he runs, and he like non-smooth gait, and he's pretty flexible besides hip extension, even though he doesn't move well on top tier. So when he demonstrates like hip flexion on what his gait looks like, he's well above like most people we'd see in here.
But was that the same bilateral?
Yeah. And the other thing with him is he's your typical type A runner. So when you tell you something, he's going like so far into it. Like by the time you're getting into like table sussing out stuff on the table. He's told you freaking everything in the world. So you're just like, okay, let's get on the table and see what your hip feels like. He's like, yeah, I feel like I just can't lift my leg all the way up. And he's like, just going through this repeatedly. I mean, you were in there for 3 of these visits, I think.
He couldn't do it, but he then proceeded to do it.
Yeah, which is a good point. Yeah, he's sitting there saying,
Multiple
I can't
times.
flex my hip. And he's like, yeah, like this. And you're like, okay. But he's saying when he runs. Yes. Yeah. Nothing apparent on a neuro exam or everything's normal there. This is where it does start to become pretty evident what's going on. So when we go through straight leg raise and supine, when we straight leg raise on the right, he's reduced on both sides. So let's say that first, but on the right, we reproduce left lateral kind of inferior. So think like ischial tuberosity area pain, which really wasn't his area of complaint, right? It was hamstring and Achilles, but he's like, man, I kind of feel that in my outside of my left hip. And then when we do a straight leg raise on the left, no symptoms in the left side or the right. So clear left, reproduction of contralateral symptoms, raising the right leg, which immediately can lead you to some things from both, whatever you want to say, a disc or McKinsey model, but also a neurodynamic model of what might be going on. And we won't, spoil it yet, but just be thinking of those lines. So then we've basically went through so from an ortho standpoint, nothing else. Again, remember, if we go back to top tier, you're looking at a lot of like the precursors to a bunch of orthopedic tests, right? Stork test, multi-signal extension, none of this reproduced pain. Remember, he can't touch his toes to save his life. So he can't even get anywhere near the 70 degrees supine straight leg raise, passively when I'm doing it, but he had no pain in a toe touch either, which is, again, another piece of evidence when things don't match. So we're basically more or less done with the exam. So I have to kind of start deciding like what matters, what doesn't. Well, his pain audit is for sure what? Straight leg raise on the right that reproduces symptoms on the left. I mean, that's like, we're going after that all day. Functional audit, you have a few things we've talked about that are in the functional audit category, because functional audits again are what? I thought we were going to say it like a unit. No. Oh, yay. Trigger points, passive joint range motion, and just tension tone would be the big ones.
Scars as well.
Yeah.
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 It don't really matter what it does.
So the glasses are just
On the side, how it kind of goes up. It looks kind of like a hat. You mean
it's got,
you mean like speed,
this-
like the Lightning McQueen?
real quick. This was a thrift shop buy.
This was Amazon buy.
This
Oh,
is
okay.
thrift.
Thrift. How well did you clean those?
I clean.
Oh, he spritzed them.
You know, my mom probably cleaned them too.
Just checking. Okay.
She's a pro.
Back at it. So we had a couple things we could pick from, right? We had trigger point, glute med men. So that's one that is objective finding. TL junction, restriction and rotation, extension. And then we also had the hip extension, prone bilateral. So those are all things that kind of matter. You also have to take into account what? General phenotype and presentation. So how old this guy is, what his activities are, and then what he needs to be able to do. So if we just kind of say, okay, what is maybe one of the most important things that a runner needs to be able to do to have a good, clean, open stride? Something that's talked about all the time. Hip extension.
Hip extension. Sorry. Hip extension.
Hip extension. This guy, again, doesn't have a clean multi-signal and extension pattern. He's having contralateral symptomatology. He's in an age range where we have to start making a decision off, okay, are we dealing with possible disc pathology? We're dealing with central stenotic change, lateral foraminal stenosis. And then when we put him on his stomach, his hip, I mean, we're talking like it is neutral. Like he is not getting beyond 0 either way. So pretty stiff, but no reproduction pain doing that. So I pick TL junction, palpation, and then also hip extension prone bilateral, because those are kind of one and the same for an extension pattern, because his pain is presenting in what? A flexion pattern, straight leg raise. So that's what I'm going at. Treatment focus, I would say, is TL junction mobility. We got to get him moved through his, TL junction. That's where you get uprighting through that, lower dotted curve as a runner. So you can expose yourself to like peak kick torque. It's not going to happen. And that's kind of what he's literally complaining to us about. And then I would say with almost everybody, it gets into what I write down as CSS, or central stabilizing strategy. Like your TL junction is probably stiff because of how you're manipulating your, internal environment to give you some pseudo stability. My legitimate diagnosis in his case would be, my diff guess would be central or lateral stenosis. I'm not thinking disc, right? You could say, oh, he has a central or paracentral disc herniation. That's why he has that well leg raise. I don't think that's the case at all. I think he has central stenotic change. And when we tug on the sciatic nerve, or whatever you want to say, the posterior elements neurologically on the right side, it doesn't move well through his back because he is literally just jammed in the lumbar extension. His hips don't move, and just you're hitting a hard edifice from a mechanical dysfunction there.
Well, saying
Yeah.
so, bouncing off that, saying that, did you do any of the neurodynamics early testing, like the whatever he calls it, the banana on the table?
So and I didn't put that in there because anything I don't put in, which I guess I should put negatives, like if anything is not in there, I did that.
Yeah.
I mean, I know that's maybe an assumption. We went through all that. We actually did lateral openers. I mean, we did all that stuff. Nothing changed, right? From that standpoint, we went back to well leg raise numerous times. And that's the, first visit treatment. This is what we did. So we adjusted mid-thoracic and TL junction. I mean, that's just, easy. We actually went after lumbar extensions, but we started with just, a sustained prone on elbows. And I know a lot of people would be like, well, if you think he has stenosis, why are you going to start with that? How are his symptoms presenting? Can't touch his toes, so that pattern's broken for sure. I know we're going after hip extension, but at some point you have to kind of take the clinical model of like, most times you would work on flexion with stenotic patients, but your end goal with every stenotic patient is still extension, because they usually lack TL junction extension and they start overloading their low lumbar spine into extension. That's why you'd be flexing them. And then what happens if you try to send a stenotic patient into hip extension? It'll peripheralize symptoms, usually into bilateral hips or down a thigh or something. Is everybody with me? That's this is a keynote that you have to make a decision of, like, I'm not following purist McKinsey model, purist, neurodynamics. You're playing the phenotype of the person. And I'm going after hip extension mainly because this guy runs 6 days a week. And if he doesn't get it, he's still going to try to. Okay. So we start in sustained prone on elbows, and immediately he starts telling me that he's like, God, I'm kind of feeling some stuff in my left calf. Remember, he had Achilles and hamstring stuff. Well, now you really have a decision to make. If you think it's stenosis, do you immediately pull back off that? If you have a disc and you're peripheralizing, you're kind of like, oh, no, different direction, because you're thinking you're dealing with a little more of I'd say a dynamic mechanical scenario. Like, I can manipulate the environment. If you have true stenotic change, you're just doing your best to do what? Get the neurologic elements to move through, degenerative changes the best they can. It's kind of greasing the groove. So we put him in that. He says it, and I kind of say, okay, that's okay. Let's keep working. So we have him in sustained prone on elbows. I do a little bit of just sustained overpressure. After that, we've already done some neurodynamic testing prior to that. We flip him over, well leg raise. All those symptoms are gone on the left. So even though it peripheralized, it took away. So it's one of my audits is on point now, and I've got to go with that. And you guys know, all the McKinsey criteria. If I send him away and he continues to peripheralize, I'm going to tell him what? Stop doing that stuff. Just don't do anything then. We'll come back and revisit it. But I'm going to send this guy home for homework now, lumbar extensions. And the last thing we did in active care that day was 3 months supine and breathing. And I fully explained why we were doing that, why, central stability and his, ability to create intra-abdominal pressure to offload his spine. If we were dealing with central stenotic symptoms, it was important to him. And he totally got it because he's a type A analytical runner. And if I'm being honest, he loves the minutia. And if you got that person, give it to him. If you don't have that person, don't, right? Just give them what they need. So his homework was lumbar extensions and dead bug. And he was going on a 4-day vacation. So we kind of had more time than I'd like. But I was like, hey, just play the next 48 hours, very aggressive, back it off. It's doing okay. Well, he's extremely type A, so I've never had a visit with him that I don't get an email. somewhere after, which I'm going to read one that comes up later, which is kind of good because it gives you more information to work with. But he comes in his second visit, and this is, I'd say a week later, I think is when he came in.
Yeah, it's about a week. Yeah.
His hamstring pain has moved down below his glute. So I know it's not moving. I said this awkwardly here. It didn't move down. It was in his mid-belly hamstring and moved up to his ischial tube, centralized. You with me there? So it moved to his like lower glute. And it is much less intense. His Achilles is the same, but he does say that his low back's kind of sore, which for me is a plus. Yeah, that's like a win. Like, dude, your low back doesn't move. Awesome. Cool. We're going after that. If I could have had his wife or somebody sit on his TL junction instead of him just hammering his probably low lumbar spine, it would have probably not been the same. But that's what you got to deal with. So I think I'm on the right track. We do almost the same thing. Adjust mid-thoracic and TL junction, 3 months supine. Now we throw in a little bit of like RT3 rolls, like dead bug rolls to start getting these kind of supine oblique chains involved. Half kneeling hip extensions on the vibe plate, which could be a death wish, but I'm honestly doing it to see if I make them worse. If I'm being honest, and that's just in the office. So we just throw them in half kneeling, triplanar hip extensions after we're doing stuff that we know is working. Nothing creates symptoms during that. Take them back on the table.
What do you throw them on the vibe plate?
So when you have somebody that's as stiff as this guy and you're dealing with neurologic irritation, the perturbations of the nervous system are no different than rubbing your head, right? So rubbing your head when you hit it, you override that, pain irritant with mechanical stimulus. You can do that nervous system with vibration. So that's all I'm doing for this guy. Get him down on a knee, shake him around, make sure he doesn't have symptoms while we're doing it.
I need some of my patients to lay on the vibe plate.
We used to do a lot of like lumbar extensions on the vibe plate in our other office, and Sloan did that all the time. And that's, because there's a lot of thoughts of what's going on, right? If you have it at a certain frequency, you're basically having the muscle is constantly having to contract to fight the vibration. That's what Thomas showed uses for those little, things that he's going to put on somebody's soleus.
That's that 60 hertz.
Right. So that's 60 hertz. So if you go lower though, the muscle is just kind of like, on like an isometric, just like you're hanging out, it's not having to constantly fasciculate. And then there's also just certain frequencies are going to compete for nociceptive noise. Now, a lot of this is not like fully proven, but that's what a lot of vibe plate info is going to run off of. And that's why if you're going to buy a vibe plate, and vibe plate is a brand, so a vibration plate, vibe plate is single planar vibration. You get like a power plate or something, it's triplanar vibration. So it's moving in all three axes, which has been shown at the hertz that they give you, plus the three axis to just be overload. And it's actually worse because then you're going to go into this like hang on for dear life and you don't get the same effect. So the hertz settings on like a vibe plate is the highest one is 5 times lower than the lowest setting on a power plate. So it's the same hertz setting almost as like kind of a Theragun or something like that. So you got to pay attention to all this stuff. You're going to do it. So at the end of that second visit, right, we ended with kind of hip extension on the vibe plate. Hip extension improved slightly in prone, right? So we're just going in, knee bent, checking passive hip extension. We can now produce hamstring pain on SLR on the left side. So you with me there? The well leg raise, the right straight leg raise doesn't reproduce it. But now when we lift his left hamstring or left leg up, he's like, ooh, that's not just tight. Like I feel that. That is a win to me. Because if he has, let's say he has central stenotic change and I can kind of get into that side, what am I showing now? Well, I'm moving into now maybe neuroforaminal change, like maybe I have some central components actually moving, and now I can kind of focus in on a unilateral side. And I might get proven wrong, you'll see here in a second. But that's my thought process now. So I'm on the right track. It's almost centralization of stenosis by seeing like same side symptoms instead of contralateral.
So if I were to pause right here, just to be like the devil's advocate. So you said that you went into like prone extension, even though you saw possibly like peripheralization early
not
on.
Possibly, we saw it for sure.
So what made you want to send him home with that, especially knowing he was about to go on a vacation, just knowing that a lot of times you send a patient, they go home on a vacation, they get worse, they're like, this guy, not going back to him.
Yeah, early in practice, probably not. I would play and I know this is going to sound contradictory because I'm going to say I would play the safe bet. And you're like, wasn't the safe bet the most often, or most common one? Not really. When I get back to, the end goal is you have to expose everybody to extension because that's the first motion that's typically lost. So that is a safe bet. But you have to play, if you don't get their spine flexing, you run into, like from an engineering mechanistic standpoint, if somebody's lumbar spine doesn't flex, it surely doesn't extend. So it doesn't move at all. So you start thinking in terms of translation, right? So one vertebrae versus another. So I think of when you send somebody home with flexion, you're like cracking a lobster shell open, right? You're trying to do this, which does what? Allows the central components to start sliding. When you do that, now you can expose them to extension without doing what? Running into no shear, and all you're doing is bumping them into the canal either way you go. And that's literally what I told this guy. I was like, I'm exposing you. And I explained every step of the way of like, because we switch it here to flexion and go back. And I only switched it because of the symptomatology.
And just because I know you, I would assume that first day you at least played around with a little bit of flexion just to see what would happen. No,
First day.
Okay.
And
I just feel like that's usually so. Just because I'm going to do most same things you do, it's like usually we'll just jump right back just to check.
But the other big note is here. What? There was no lumbar restriction and flexion.
Well, and I feel like that's the hard part always with the podcast is you can't ever see the OG SFMA.
Yeah. So like when I put them on palpation, there's no, counter nutation restriction. There's no lower lumbar flexion restriction. The tough thing with a true stenotic patient, like I saw a guy today that is a horse farrier, like horseshoer. I mean, you ain't moving that guy's spine. I don't care how good you are, Mitch Malley bullshit, whatever you're going to do, you ain't moving that guy's lower lumbar spine. So whether you say you're going to have that guy flex or not, it ain't happening. Yeah. Piezoform, maybe. All I'm saying is this guy, you could palpate. He's a wisp. I can move him around and I could clear as day be like his TL junction is like hitting the table. Everywhere else, not the case. So that's why I say, we'll go after the thing I'm going after. Had he had both, you have a really hard decision to make. Right. So yeah, that's a good piece to talk about.
Was he also, when you were initially doing the extensions?
It's so hard for me to be serious with the goggles over here.
When you were initially doing the extensions, he was peripheralizing during, but after he was no worse, right?
Better.
Oh, he was better.
Remember, the well leg raise didn't reproduce symptoms on the left after doing
it. But at rest, he was not.
Right.
Because he had pain.
So that's another part of it, yeah.
Well, and you may have said that, and I just totally missed it because then I looked over at Alex with these dang goggles on, and
as we do with everybody, I overemphasized what? If you peripheralize while you're gone, quit.
Yeah.
So we do that with everybody. I think you need to scooch up here, goggles. Sloan said she needs more of you. It's good, great questions, because that's kind of stuff I need you guys to ask too. If you're like, why the hell is he doing this? Why was that decision made? Don't let me go all the way through it and then go back. Be like, whoa, time out. Like, what is it? Because this needs to be a combo. Like, don't just, that's why you guys are, you're literally, paying to be here. So like use it. So that was end of second visit. So end of second visit, homework. Dead bugs, extensions just less frequent. So our typical kind of thing is what? Hey, you're going to do these every hour for the next 48 hours. After that, go down to 5 to 6 times a day. Then we go down to 2 to 3 times a day. Then it becomes like a morning and night thing. That would be a very typical, parsing out of homework. So third visit, I think it was about another week. No, we were trying to do 2 times a week. He had that vacation. So we started seeing him twice a week there for a while. Achilles pain is getting better, but his hamstring pain is still getting worse with harder efforts. So this guy is not stopping running. I haven't told him to stop running. He's still going to the track. He's still doing when I say he's doing track workouts, he's doing 300 repeats and 200 repeats.
3 track workouts a week?
Yes, which that's coming. That portion of the talk with this patient is coming later. So
you're an idiot.
Hold your horses. Yeah. That's coming. But I want to
he's trying to work up to, I know where it's 600, 600, 600.
Yeah, that's his goal. So Seth brings up a good point. He thinks when he can do 600, 600, 600,
he is to run a mile under 5.
Healthy.
And then he's healthy. Yeah.
Interesting.
So as Daniel said, well, why would you send somebody home with something that can make them worse and possibly lose a patient? I definitely would have lost this guy to patient if I started trying to coach his running after 5 decades of running at this level. He's probably faster than me right now. I'm not going to do that on the first visit, but I also know that there's something I need to address when I do start to see better results and have buy-in. So yeah, full circle there. So it's a circle. Pain still getting worse with harder effort. So what do? adjust his mid-back, adjust his TL junction. Now we do what? Flexions.
Yeah.
So why am I doing flexions now? I am not a purist of any methodology. As I said, if you had to think about, I think we think of the spine different than any other joint. If somebody came in and let's say they didn't have extension or full flexion of their elbow. Well, if you've taken a McKinsey class, you're going to pick one just because they told you to pick one. Right? You're going to be like, I'm going to extend the shit out of that thing first. That's what you're going to pick, right? Well, if a joint doesn't move, you'd be like, well, it's got to move both ways. It's not a preferential bias. You'd be like, yeah, you have to eat. Maybe like, oh, flexion is more important. Well, let's just think it's a joint. Your low back is a bunch of joints. It needs to move. So now I'm saying, well, his hamstring's not getting any better. We got to move through extension. We, centralize a little bit of it. I don't have to go further. You might say, well, you explore more hip extension, explore more of this. I can run an A/B test. I can have him do this for 48 hours and see what happens. There's nothing wrong with that at all. And it's not like I'm like, don't know what's going on. I 100% at this point know what. It's not a disc issue. It's centrally provocated because he has, bilateral symptomatology that we can change working centrally. I mean, this is just like, you kind of get to play now and be like, okay, what happens? Well, I can go with the lateral component. I get like all these things are options. You could pick something different and maybe be faster than me, maybe set yourself back 2 visits. There's nothing wrong with that.
I think also though, like it's something that you try to tell us and stuff is like, you need to prove yourself that you're either right or wrong.
Yeah.
Because a lot of times like early in clinic, like something shows up with the peripheral symptoms. Like if like we're in clinic or if that patient walked in and I push them their like TL or lumbar spine and it sends symptoms on their legs, I'm probably like, I'm backing off.
Mm-hmm.
But you had to like you said, you always tell us you're like, you need to prove yourself wrong, whether it be a visit or two.
Mm-hmm.
You need to see it all the way through. And then you have to say like, are they better, same, or worse? And that's based on your audits. And it's always like your pain that you're talking about. But
Mm-hmm.
you have to then circle back and be like, all right, I need to go after this now
Mm-hmm.
because I know it's not this.
Yeah. And I wish I could tell you this is adhering to some methodology like, oh, SFMA says flexion's a primary pattern. So I'm going to try to go back to a primary pattern. Like I'm not. I'm just going, your spine needs to move. We did extension. We had some change. Let's go after flexion, see what happens. So during that, we lumbar flexions with overpressure. Oh, yeah, go ahead.
So why would you wait that long though?
The only reason I'm changing direction is because his hamstring's not responding. So his Achilles is like, he's like, my Achilles bugs me in the first part of the run, but then it's nothing and I don't feel it any other part of the day. His hamstring at this point is still like, if he sits in a car, like on the way over to the office, it starts bugging him. First part of his run. So I was like, okay, instead of just trying to completely shove extension down his throat, I'll go back to the safe play and I'm going to expose him to flexion and see what changes. It does not mean that I have him stop doing extensions, which you're going to see, which seems counterintuitive. But if I could relay my thought process on something like McKinsey, is don't think there's a right or a wrong or a protocol. Joints need to move. I mean, maybe that's an Andrew Espina sentiment and get them to move. And they need to move in all 3 axes. And in this case, if you think of your spinal cord and the tube that surrounds it, it should make sense that it just needs to slide around it. However you get that happen, go for it. That would be why I'm thinking like that. Does that make sense?
Yeah. Yep.
Cool. Where am I at? So lumbar flexion to overpressure. So while I'm doing that, he's kind of noting that he feels that it is like left ischial tube. He's like, I kind of feel that with every flexion, which I'm like, yeah, okay, whatever. So after we get done, reduce left hamstring SLR, because remember, we're on that left side now, we're not on the right, symptoms, and an increase in passive range of motion. So he was at about 70 degrees, and we see that thing kind of spring up, and I'm like, and he even was like, ooh, that's better. Cool, that's self-reported, right? So now we have an objective and a subjective account, passive range of motion, subjective, like that feels better, and he knows it's better. Cool. We also work on what? 6-month plank, which you'd be like, well, that's not extension. No, it's anti-extension, which helps him actually expose his hip to extension. 6-month plank. And then we actually did what? You did Jefferson curls with this guy that day. Because I thought, well, there's no way this guy that's going to go run 5-6 times a day, slamming his lumbar spine into extension, trying to at least, even though his TL junction moves like crap, is going to get his lumbar spine to flex. Remember, he touches his toes and he's like, I mean, I don't know, 3 feet away from his toes. So
We've been over actually. That's it.
he doesn't change position. He goes, I'm touching.
You said try again, and he's still trying.
So I think we used 20 pounds, and he did that. No symptoms during, no peripheralization, no exacerbation. I don't think he also said like, oh, I feel amazing. It's just like, yeah, cool. We didn't send him home with that. I just want to see if we loaded that. And then also during that period of time, which is going to happen in the clinic, we had probably 5 other patients that we were just kill shotting stenosis stuff with Jefferson curls. And we're like,
Jefferson curls we did the past month is pretty.
So just we were rolling on it and we're like, let's see what happens. And I know a lot of this seems like we're just doing experiments. Welcome to practice. Cool. So what was his homework now? Dead bugs and lumbar flexions. After workouts, he is still doing what? Lumbar extensions for sure. But I was like, hey, if you start having symptoms, like that's the thing I want you to go after is just lumbar flexion. See what happens. I'm literally running an experiment based off symptoms. So that's what I sent him out of there with. So then he comes in for the force visit. His Achilles is doing much better, but not completely gone. But he's like, if that was as good as it got, I'd be happy with it. And he was really worried. There was also a psychosocial component here. He was worried he was going to rupture his Achilles and not be able to run ever again. He kept bringing that up. Like, I thought my Achilles was actually hurt. He had no tenderness on palpation, no edema, no redness, nothing on exam, right? So that's where I was like, okay, like, it's out. We had a hand raise.
Yeah. Are you pretty transparent with him about like you are running this experiment? You're not, I mean, it probably depends patient to patient, but how transparent are you with him?
I'm very transparent at this point in my career. I mean, they can tell you if I'm lying or not, because I think the way you present it matters. Obviously, you're not just gonna be like, hey, I don't know what the fuck's going on. Let's try this. You're saying, hey, I know that I can't hurt you, even though symptoms may be provoked with this thing. And I explained in his scenario, I said, you may have symptoms, your back still has to move. And he gets it. He got it from the start. So I knew how to talk to him from that point. Let's say I had somebody that wasn't responding to me very well, right? Like we're just not jiving. Like I have a very type A, nervous, high profile lawyer that I'm seeing that's a female. There's no way in hell I'm doing this stuff with her. Like where I'm like explaining it. She's kind of a high level scoliosis case. I would never do this stuff with her. I had the ability to do with him. So it's a really good question because not everybody you're going to be like, yeah, freedom of access. Like you have to kind of play around with it, make sure you're going to have symptom relief, like Daniel said, so you don't just like send them up the wall and they're like, what the hell? So that's a good point. But I'm really transparent. Like, dude, your back's got to move. Let's explore both ways. If it's worse, we'll just about face. And I don't know, for whatever reason. I mean, he also told me coming in like, dude, you're the guy I need to see. I saw you're into this stuff. And like, so he was just kind of like a fanboy. I was like, okay, let's put him through the ringer.
I also think if you've been around Beau for longer than a month, and if you just watched him practice, then you immediately become more transparent with every patient you ever see. Like you're just gonna like let them know straight up, immediately like, hey, you're gonna go do these things. You're either gonna be worse or better, and we'll see, and we'll change course then.
And the compliment I'll give Daniel off that one, which you just got another review last night from Deanna. Most of his reviews are like, I learned so much. So what I have learned, this is a little side note, but sometimes we get taught to do what? Not over talk during a visit, not educate too much, talk down to people a little bit. I'm going to tell you, I think most of this practice success is actually doing the exact opposite. Talking to people at a higher level, telling them what's going on, because that's what the reviews say. Literally, if you go look at all the reviews, people are gonna be like, Jesus, I got better, but what I learned like was amazing. So talk about what you know, like weaponize it. Don't feel like you gotta like fit into this business model of like, oh my God, I just got to treat this person to make them happy. Like, no, it's like, if you want to be a source of information, do it.
And parents like that too.
Yeah, parents do to a certain extent, and you get the nervous Nelly parent. You can.
So I feel like all the parents I get, they always ask me a ton of questions. Maybe it's because I look like I'm 13.
Well, you can fix that with that mask.
Okay, but
I might be done 12.
Huh?
It might be done
12. But yeah, they're always just like, I mean, that's their Michael Jordan sitting on their table right there. So they're kind of like always like wanting the very best for him. So
Michael Jordan on the table.
Did you ever tell him, I know you think it's a Michael Jordan on the table. It's really more like a Shane Gillis with his tongue out the window.
I don't look in the mirror.
Yeah.
Might be realistic.
Homeboy's 5'4".
All right. We gotta get through my case.
Yeah.
Okay, so his Achilles doing better. Still doesn't feel fluid when he's running, though. His left hamstring is still bothering him in terms of pain, but not impeding runs now. So remember, that's his big goal, is like running, having that fluid gait. He's telling me now that he's been warming up with 200 to 300 yards and then he has no issues whatsoever. Achilles hamstring, it's gone. Afterwards, like when he gets in his car, gets home, it's still kind of flared up and his hamstring, Achilles is basically not there. Yeah.
Is it still like ischial 2?
Yeah, it's always, now it's ischial 2, maybe it goes down a little bit, but yeah, it's ischial 2. So that's showing us
So it
again.
didn't go higher than
No. And what do we also, or I'm always kind of trying to think, like ischial 2, we talk about all the time, is what cutaneous nerve wraps right around it that actually, posterior cutaneous femoral nerve, which is going to, come off femoral nerve. So it's a different type of, like, it's not branching off sciatic. So that's going to be exposed to extension kind of, provocation. So that leads us back to the extension thing one more time.
Also, just a random thing. I know you're trying to get through your case. What makes you not think it's like hamstring tendinopathy at this point? If you've seen it this many times and
And again, I did not say that. First visit, we test the snot out of it. Do you remember? Was it third visit? So the first 2 visits, we test, what is it? 90, 120, 150 degrees of flexion prone, where you're just resisting hamstring, no pain. Third visit, before we did flexions, he was getting lit up and I was like,
and he was cramping.
And I was like, and then we did flexions and we did retest that. So again, thanks for bringing that up. Yeah. I mean, there's so much stuff in these that it's hard to be like, God, what all do we do? But yeah, we did repeat flexion. I like that you're getting hurt with the boot and we're drinking bourbon. Oh, God.
No. I'm saying that was not very good.
You didn't like it? I thought that was gonna be your favorite flavor.
Okay. We'll make it through this one. Adjust mid-thoracic spine and TL junction. That's the theme. Dry needle lumbar spine. When I'm dry needling his lumbar spine, it's biased towards the left side, and I'm trying to go as deep as I can into like multifidus, thinking that stimulating proprioceptive muscle fibers is now going to be the thing that kind of helps me like offload any compression that he's hanging on to if he has central stenosis, because you still have to try to get axial extension as much as you can. That's the goal, right? We're still hitting 3 months supine. We're still hitting, now we're adding 6 months supine, right? So happy baby. So we're trying to knock him into active flexion. And then we're starting to do some like hanging stance, but I'm doing it more for like a neuromobilization. This is something that we talk about a lot that I don't think gets talked about enough. If I have somebody in a hanging stance, you're in an isometric hold, obviously. When you contract the muscle isometrically, you contract it in 3D. So you create a bigger channel or foramina for the nerve to slide through. So we can have somebody statically hold. Well, as you statically hold, the nerve is still sliding, right? Because the muscle is constantly contracting. It's not just static. The muscle's pulling towards an insertion or, an origin. Everybody with me on that? Because this is like a huge deal. You don't have to sit there and floss somebody to have a nerve being actively mobilized. But then you can also have them do what in hanging stance? Try to back into knee extension a little bit and come back out and start working it in this isometric load, which for him is, I think, wildly exposes how much that affects his hamstring. Not necessarily pain, but he's like, holy cow, that is like really, really tight. So again, for him, it solidified something. And then we just did some traditional, single leg RDLs. We talk about his training regimen in this visit. So I went through the whole visit and I prefaced it with, I'm never going to tell anybody what to do, but I just want to kind of have this conversation that I think I brought it up like this. I said, how many days a week or how many days during a typical training cycle do you think a pro runner is doing a hard track workout? And he goes, 2 to 3. And I go, okay, let's back up. How many days do you think are in a typical training cycle for a runner? And he goes, 7. I go, 10. And he goes, okay. And I go, how many out of 10 days do you think there are hard workouts? And he goes, 2 to 3, maybe more. I go, 2 max. And he's like, oh no. And I was like, I promise it. Like if we're doing a track workout that's going to expend, you guys know all this from an energy system standpoint, recovery. So I walk him down this path, literally charted out. And it was cool because we kind of walked it down to, he was like, well, I do a pretty hard, shorter interval day, a medium interval day, and then a long interval day. The long interval day was like 1500s. I go, if I had to get rid of one thing in your state, it would be the long interval day. Because you're going to go under neuromuscular fatigue, break down your mechanics. And when you have a breakdown of mechanics, you're more likely to perturb this stuff. That made sense to him. So I didn't have to tell him to stop running. I didn't even tell him to stop running. Just like, go do another easy day in lieu of that. Totally on board. Because when I first brought it up, he was very opposed to me talking about his running training, because he literally writes this out in a spreadsheet and probably puts it in a frame at the end of each week. I don't know what he does with it.
Well, even at his age, and at his age, if he sticks with the shorter stuff, like that's going to be the thing that he loses the quickest.
And I 100% brought that point up. I go, yeah, what do you lose? Power output, max power. And I go, you don't do any weight training. So I go, if I had to pick something, it would be keep that. You also have better running form the faster you sprint typically. And if it's not hurting you, go after that, which he thought that was the first thing that should go. I'm like, no. Like easy runs, higher intensity VO2 max intervals or short intervals for sure.
Well, the one thing I was going to make sure everybody like thinks about, like with what you said, like you threw him in a drill, but you knew exactly why you threw him in a drill.
Mm-hmm.
And it's like that, like we talk about that a lot in here. It's like, don't just throw a drill at somebody just to throw a drill.
100% goal oriented.
Yeah.
Yeah. And what also is off on his top tier SFMA. So there's only two things that he had that were perfect. Single leg balance. So single leg balance as a runner is huge. So now we're starting to work him into single leg stance stuff, which I explained that to him as well. So you're always just like, concentric circling around a patient of like, we're working on all the things that you need. Yeah, you want to be out of pain, but I've got to solidify your movement to make sure you don't get back in pain. At the end of the fourth visit, he is still going home with lumbar flexions and single leg deadlifts now. Single leg deadlifts, exposing him to some, and we're talking with assistance, like hand on a wall or door frame. But also I can have him do what? He's neuromobing now as we think we're getting his lumbar spine moving. Okay, let's go out to the periphery and move. And it doesn't have to be a seated sciatic flossing or something like that. Like you can play with this stuff. Because again, Kyle's been with us forever. If you understand the principles, you get to play with this shit like you own it. So just like make it your own, right? Fifth visit. Achilles is a non-issue. So he's saying that's resolved. Hamstring is still worse when sitting for long periods of time, but doesn't affect him during a run at all. So saying if I sit in my car, especially after a run, like I still feel it, but like I don't feel it throughout the day, don't even feel it in the beginning of a run. What do? Adjust his mid back. Remember, he came in with a little like thoracic kyphosis, so we could just blow this guy up every day of the week. TL junction, we dry needle his lumbar spine again, just for, kind of stimulatory effect. 3 month supine to 6 month transition. So you're in a dead bug, you're trying to actively pull yourself into a 6 month transition. It is tough for this dude. And guess what it recreates? Left ischial tuberosity pain. Perfect. Like I want that all day long. Because why? He has a shitty synergistic program around his central stabilizing strategy, which creates undue compression. When he does that, what happens? Neurologic compression creates symptoms, because when I passively flex him now, there's none of that. So it proves that it's how he's doing it, not the movement itself. Beauty, right? We do hanging stance neuromobs again. We do single leg deadlifts with a little bit of weight, even though we probably shouldn't be, because he still can't balance. And I'm not a big fan of just like jumping that fast. So I sent him home at the end of that visit, and then he was going on a 2-week vacation to the beach, just getting around Christmas and stuff. Lumbar flexions, single leg deadlifts, no weight, right? Assisted as needed. And then trying to work on this 3 to 6 month supine transition. That's all we're working on. So I have not seen him since then, but I got an email.
It is.
So I know this is a little long in the tooth here, but let's read this email.
Long in the tooth. Canine size. Yo, sharp tooth.
So he, let me move this over here so I can see the smiling faces.
I mean, you'll notice.
I know.
So it says, between visits update. Good afternoon, Dr. Beard. I trust you and yours enjoyed a healthy holiday break. Since I won't be back until January 9th, an update. I've gotten the hang of the dead leg lifts. I don't know what that means, and the supine dead bug, that's a single leg deadlift. Even getting closer to catching my toes now, at least on the right leg. Still a challenge for the left. Still getting into the rhythm of bilateral sciatic stretch. We'll need to confirm proper form for next visit. I've seen dramatic improvement, especially in the hamstring. Woke up one morning and for the first time in months, simple activities like putting on a pair of shorts or getting in and out of the car didn't hurt. And it has yielded much better running form, feeling more relaxed through chest, shoulders, as well as hamstrings, foot pain since the last seen you. Then he gives me his whole workout he did for that week, showing me that he didn't do those super hard intervals and he did some easy runs, which, yay. He was at the beach, so that kind of hindered, the track workouts. And I'm reading this so you guys can play around. We did this experimentation and it's nice to feel like a runner again. You can see times returning toward normal, albeit not where I want them to be yet, but one step at a time. We'll slow down a bit and try 6 miles tomorrow and spend the next week rebuilding. And then he's asked me for suggestions on training now, which is kind of ironic. So that's kind of the wrap of that case. So obviously I'll see this guy next week and hopefully still doing better. No clue. He could blow back up because with stenosis, it is what? It is management, not fix. Most things are not fixed anyways. So he's kind of a cool case because he could have been a flight risk. Like that first visit, he was just like a little hopped up, but as soon as we started talking, it's like, okay, we're good. So any questions from you guys on that? Any questions from you guys on that?
Yeah, I just had one about
the
neuromobilization in the single leg deadlift. Is there a reason you chose that instead of just like the classic sciatic tensioner or flosser, just because it's dual purpose with strength as well? Okay.
Dual purpose. And if I'm being honest, so this guy has terrible range of motion to begin with. Remember, he can't touch his toes. He had about a 70-degree straight leg raise when we're supine. So when, in my opinion, you put somebody in like a seated sciatic flossing maneuver like that, I don't even know if he can get there, which we would still stay as neurologic, but you'll see he has a really hard time getting into extension through his TL junction, which you need to do, right, to offload your lumbar spine to get into a flossing maneuver. And I just think it's a better move sometimes to load the musculature around something like the sciatic nerve to create that bigger opening, which, Shacklock talks a lot about, Stecco talks a lot about, of that 3D, as I put the post up the other day, it's an ecocentric contraction, not necessarily isometric. And that's something we're going to play around with more because we talk about it a lot of can you get more bang for your buck in an isometric, whether that's static or nerve mobbing? Test it. I mean, prove yourself right or wrong again. I don't know, if you floss somebody's seat at one time and it wasn't gangbusters and you don't do anything different, just change how you did it. And you're like, ooh, that was better. Yeah, there's a couple different things going on there because then you'd be like, we're doing DNS too. Well, maybe, I don't know. But I see success with it. And yes, we were starting to stack single leg stance. He needs to probably do more posterior chain work in general anyways. So I'm starting to lead him into strength and conditioning, which he does none of, and trying to get him sold on the fact that dude, if you would pick up a weight, you might not break your hip when you fall on the track in 5 years because you have never done that. So yeah.
Well, and I'll say this is that's one of the ones with Z Health and Eric Cobb. I like his sciatic flossing better than I like Shacklock's. And so it's just
there's a ton of,
nuance to it.
And I would say Shacklock's the king of nuance, but then also I would say what I was doing is less nuanced, right? You're loading him, you're saying just kind of hang out here. Can we just kind of go through minimal ranges of motion? You could also say, well, that's going to make them worse. Because some people would say, well, is it a flossing maneuver? Is that a tensioning maneuver? It depends on where you think the movement's occurring, right? So if he can't get into lumbar extension, it's automatically a tensioner. Doesn't matter what position you're in from there. If I take him through hip flexion, it's already a tensioner no matter what. So anything I do with this guy technically is a tensioner, even if I'm trying to floss him. Unless I lay him over a foam roller or yoga mat or something like that, which there are 100 paths to Rome with every patient, and that's the game. Why do we have balloons?
Touchdown.
Was that a
happy birthday to my son?
Is the path to Rome a secret code or something? But that's kind of the fun, right? Is ooh, Beau did it this way, I did it this way. What were the results? It's an impossibility because you don't get to compare, patient to patient. But yeah, it's all great questions. And again, you at some point have to go based on what you find or what you've been taught or that patient in front of you, hopefully.
I got a question.
Yeah, I knew it.
I got a question. Oh yeah. So when you're having the conversation with him about how you manage him, right? How did you strategically approach that? Right. I mean, you were saying you're just being blunt. Yeah, no, not just the running, but from a symptom management perspective in the beginning, especially with stenotic patients, they tend to respond not very quickly, right? So how did you do that?
It's kind of almost hard for me to explain this point because it's just like it's just how I operate. I know that sounds kind of like, oh, thanks, but like I don't do anything different with any patient now. And I mean, they'll tell you like there's very few people I'm going to try to like, ooh, I'm going to dance around this because I think like if somebody's not a good fit for me now, they're not a good fit for me. We have enough clinicians in here and I've been around, I don't need somebody. So that's like harder for me to say. What I will say though is that actually tends to work better for me. So instead of me trying to be like, oh, I need to win this person over with this certain methodology first versus like, dude, I'm going to tell you how it is. Now I'm not, extreme with it or, blatant or like overbearing. I'm just like, this is how it is. And this guy was very into finance. Like you could mistake him for an engineer, type A runner. So I knew how to talk his lingo because I knew he was going to talk mechanics and just everything like that. Also, remember, he front loaded me with, hey, I saw you wrote a book. I know you know what you're talking about. I saw that you're a runner. So he has this kind of bias already that I'm like an expert in the space. So then I wanted him to know that I was. So I was kind of like, yeah, this is why we're doing this from a mechanistic standpoint, not necessarily like, hey, let's get your back move and go do some extension. We'll see what happens to symptoms. Like that kind of dumbed down version of like, well, let's not explain what's going on. I mean, I explained it very in depth the first visit. Now I just 4 of my patients today were kids. That's never going to happen with them, even to their parent, right? So then I have to be like, okay, that's a very different scenario, but I'm no different with them. I'm just not going to go into the detail. So I had a kid that has high level neurologic stuff from a torticollis issue when he was a baby. We're doing like a bunch of reflex stim. I'm trying to explain like Hoffman's reflex to the kid. Like, why are we using that thing as an audit? That's not the easiest thing to explain to a kid that doesn't really have a bunch of issues besides like some speech issues from development. You know what I mean? But I'm still going to try to explain it and he gets it. And I think he appreciates it. Like he seems to like to come. Yeah. So I know it's kind of hard for me to answer at this point because I'm like, that's how I operate is like, I'm going to do the same thing with everybody. And if somebody kind of didn't fit my bill, I would try to get him with somebody else in here, or I'd be like, see you later versus like a year into practice, be like, dear God, give me money. I gotta, my practice has to survive. So it's just, I'm in a different phase. So I know that's not super helpful. Yeah. Give it a Seth. Seth knows it.
I think that helps you.
Yeah.
I mean, I think that helps you. I mean, if you're in your treatment room, that like, if you're a parent or if you're a patient, like if you feel confident in your clinician, then like, you're like, okay, I don't really care how they are. And it's kind of like when we refer to orthos, it's like, do we want the best side man in the world, or do we want the best surgeon in the world? Like in Birmingham, like we kind of have that luxury.
Mm-hmm.
And it's just like, we kind of read the patient.
And I think I probably came off, well, I know I did. I mean, I got told by, my resident and my residency advisor, like I probably came off as cocky early in my career because I wasn't actually confident. It was kind of mimicked. Now it is confident and it's just so confident. It's like, well, I just run through the thing and you still got to be personable. You have to build a rapport, but that's just to me being a person. It's not trying to do that. I'm not trying to be personable. Just go be a person, like find out about them and then tell them exactly what's going on. If they don't like that, like, but I'm telling you, man, like, this is the, the behind the walls residency, you guys being here, like, dude, use that. Like you guys are all here because you're going to be top level clinicians or already are, like weaponize that stuff. Talk to your patients. Doesn't mean like word vomit on them, but if they want it, give it to them. Right. And if there's something, I mean, we had a guy that's like probably going to be a pro soccer player that we sent immediately for an x-ray. And I was like, I gotta make sure you don't have a fracture of your foot. You could tell he was instantly like, versus like, let's just check and see what's going on. Like, trying to play the game and not telling like, no, I just gotta make sure. And I'll see you Monday either way. I mean, so yeah, I'm just in a different phase, but I think that earlier, like Daniel said, you can get to that like point where you're just confident and like telling people what's going on. Like it's a better play for you. Or just be a giant dick and just, be like, dude, shut up. I'm smart. Like, listen to me. Do what I'm doing. Yeah.
I disregard that slide on the R2P fundamentals.
Don't be a dick.
Yeah.
Is that
Yeah.
what Seth does when he walks into the patient office with those goggles on?
He he just waits to like see what the first interaction is. He'd be like, I'll be right back. And if he doesn't get along with me, he goes and grabs that. Yeah.
Yeah.
That's typically what it is.
Dr. Wasp at your service.
Building rapport 101 with Seth.
Yes, R&R. All right. Any more questions on that case? And remember, we're going to do a Q&A at the end of this for, it could be general stuff if you guys want to hang out. I know it's Friday night, you might have stuff to do, but we'll do a Q&A at the end. So if you think of something, even if it's outside of these cases, let me know. Okay. Goggles.
All right.
You up.
Oh, also, Aaron, I didn't see you there because I had, there's a little peripheral block out here. But what's up, man?
What's up?
I'm gonna be honest right now. Take that thing off so you can do your
Yeah,
case.
you can do the case with that on. Yes.
We're gonna be here until tomorrow.
All right.
Oh my God, that's like walking into the morning.
I feel like I have a ring around my face.
You do.
All right, very dark. All right.
Sorry, Mike, so yeah, did you?
All right, so 28-year-old male with chronic low back pain, several episodes before he had seen me, and radiating symptoms into his hips, left worse than right. We're starting this case in like summer of 2022. So I was seeing him during preceptorship, and as I was going back through all of my visits, I was telling Seth, I was like, yeah, definitely didn't know what I was doing at this point or at that point, and remember us talking about the case. But I've seen him, I guess, twice since the two trial cares. Pain with prolonged sitting and getting in and out of the bed or canoeing. He's really active outdoors. He works for a company around here, Coosa River Keepers, and he's always outdoors doing things. He has increased symptoms with coughing and sneezing, not really worse in the morning, just constant pain throughout the day and increased with certain movements. He had been, like I said, been treated from June to September of 2022. And do you want me to go through any of that?
Not in super deep, just high level.
I mean, dysfunctional, painful, multi-segmental flexion and deep squat. The only DN was extension. So we ran through that for a little bit. That made his symptoms worse. Made his symptoms worse when he came back the next day. He wasn't any worse that day in visit. Then after that, I was like, okay, we'll start exploring the lateral component. Got a little bit, he would always get temporary relief with a lateral shift or an opener, but then it would go right back to where it was. So treated him 4 times in between that time. Then I kind of, from like June to September, I didn't hear from him. His wife is a nurse practitioner, and he had gotten 2 steroid injections over that course of a couple months there, to which he had immediate relief, but obviously eventually it came back. He got an MRI. The MRI said he had a congenital spondylolisthesis. Don't really know what level, or I didn't have a note of that because he didn't know it. And he was back into the gym doing minimal activities, but wanted to kind of work on his core. Because at this point, his symptoms were better. They weren't gone, but they were better because of the injections. So this is, actually, I guess we've had 3 trials of care. Because then from September to November of 22, I saw him 5 times. And at that point, I was trying to actually work on lumbar flexion because I knew it was limited before, but it was painful for him to go into flexion, so we didn't really go after that very much. But now after the injections, he was able to handle it. So again, kind of the same thing. We worked on different positions that loaded him into flexion. He would get relief during, not really have that much change after. So then at some point, I guess it was the end of November 22, he had a microdiscectomy. I found out about this the next September, so almost a year later. We knew about it. He didn't come back in until about a year later. Said he had the surgery, and when the surgeon got in there, he said that he didn't really see anything that he needed to take out. He mentions, sorry, I didn't know slow.
You're good.
Question about the tech. He mentions that the surgeon saw something around one of the nerve roots that was like an odd bundle of something, but he didn't really know how to explain it. But they didn't really excise any disc material or anything like that. You know, that's what they were going in for. He got temporary relief from that, which, you know, like I said, it had been almost a year since he had that surgery. But at that point, he was like, I'm starting to get some, my low back pain just came back on only the left side. And now I've got radicular symptoms all the way to my foot and tingling numbness all the way to my foot. So he had started reintroducing general movements like walking, stretching, biking, swimming at the gym. But it wasn't really getting much better. So still having pain with prolonged sitting. He's very limited in trying to touch his toes. Beforehand, he was pretty stiff in that anyway, but you could tell there's an asymmetry in him being able to actually extend his leg like in a slump. So a true limitation, a true nerve tension on that side. So he also, oh no, I'll get to that in a second. So top tier that day, this is this last trial of care. Dysfunctional non-painful cervical extension, multi-segmental extension, and right multi-segmental rotation, which wasn't out there before. Also on the multi-segmental extension, that might have been the most like shaking that I've ever seen somebody, which he did not have that previously when he was going through that motion. And then dysfunctional painful multi-segmental flexion and left rotation, which again, the rotations were not limited or painful last time either. We already mentioned the positive slump, decreased range of motion. This time he's also got decreased S1 reflex on the left. So that day, the only thing I really did was put him in child's pose. Put him in child's pose and breathe. And then that improved his slump range of motion a little bit. So I sent him home with that. It's like, that's all we're going to work on for now. Comes back. Again, breathing helped in the moment. Radicular pain and tingling return almost immediately thereafter. Swimming seems to help for when he's having issues in the morning. At this point, I remember Tanner Zimmerman was in with us, and he had a lot of experience with using McKenzie at the VA, where he had seen a lot of like true neurodynamic signs at the VA with people who had tons of nerve tension and couldn't, you know, fully extend their arm at all, or their leg or something like that. So we played around with tensioning sciatic nerve a little bit. He would get kind of zings down the leg during, no worse after. I said, hey, why don't we try doing some of this at home and see how it responds? He had a big event coming up that we were kind of trying to get him prepared for, and in order to be able to handle it. So the next visit he comes back, he's felt pretty much the same throughout the day. Come to find out, he was confused on the tensioning and floss. So yeah, again, no worse after doing the floss. We went and looked at remember how I mentioned how he was shaking a lot on that extension. We have worked on breathing. I've worked on breathing. You've worked on breathing with him before. What I noticed this time compared to seeing him previously, in the lower abdominal area, he was really poor at being able to create intra-abdominal pressure down there, which I don't remember that being the case before. Bite to it. So
you a shot out of your goggles.
So we're breathing, and then we did some Jefferson curls in office. Didn't send him home with those because they were again same, no worse after.
Yeah.
No change in the homework. Had him still doing the breathing, and now focusing on that lower abdominal zone. Visit 4, he had the working the fishing event for Coosa River Keepers. And that he was like, that was absolutely terrible. He was up on his feet all day, didn't really get any relief if he was sitting or if he was standing. Tried doing his, his flexions and his breathing. Again, it got relief during, no change after. He tried doing another steroid shot that his wife got him. This time it did not provide any relief. So that day I was like, okay, let's just do something different. The new thing that had popped up before was the rotational deficits. So I was like, let's go after that a little bit. We put him in a rotational plank on the left side. That increased tingling in the leg. So I said, all right, I'll do that. Let's go on the right. That did not reproduce the tendon. And minimally changed rotation. So I was like, okay, probably not that big of a deal for him. Then he had a wedding. It was more tolerable than the fishing tournament, but
like he got married.
No.
He had to go to one?
Yes.
I was just checking.
He did get married though in like the previous trial.
That's why I was asking.
Actually, it might have been his because the honeymoon was in here somewhere. I don't remember.
Not patience.
Bedside manner, guys. If it's your patient's wedding versus them going to a wedding, might want to know. It's just different. It's different.
What visit are we on right now? Just one?
Well, no, we're on trial of care number 3.
Okay.
Because I've seen him over like a year and a half.
Seth, are we on visit 1? No, this is 3 years later.
Okay, I'm just making sure. I heard you said you were catching up, and I didn't know when we ever got.
I saw him 2 summers ago, and then I saw him that fall, and then we didn't see him for a year, and now I've seen him this fall.
It's been very spaced out.
Okay.
Yeah.
That's how I was curious.
We're on visit 5 of this fall.
Of the newest one?
Yes.
Yes.
We're almost done.
Like crap.
Good luck.
Time travel? Yeah.
What's your differential at this point?
I mean, lumbar radiculopathy.
Okay.
Yeah. So
You caused by what?
it is.
Okay.
Yeah.
Even though their congenital spondylolisthesis is thrown in the mix,
Yeah.
right? Now he's had a hemilaminectomy, correct? Or he had discectomy?
Was supposed to have a discectomy. It didn't really.
They didn't do anything?
Well, they got in there and then they didn't remove any disc material. Yeah. That's what they were. That's what he reported to me. He said they got in there, said that
This is the first surgery?
Yes.
Okay.
Like in 22.
Yeah, okay.
A year ago.
Yeah. Timelines are, this is like I don't know. Who's the director of like Inception?
They got the whiteboard out.
Yeah. I need some direction.
You're telling me?
Christopher Nolan.
We're on visit 3 years later.
I'm just saying
We need a spinning top. We've got a whiteboard. We'll draw it up for you. I'll put it in the show notes. We'll have the timeline.
Okay. So the wedding.
Yes.
Right. More tolerable than the fishing tournament, but still had constant pain without much relief. Again, he had kind of gone back to, he's used different things in the past. He's like, I tried doing the left side glides. That didn't do anything. Or again, helpful during, no change after. And then he was like, I tried some of the rotational plank even, and that actually made it worse. So I stopped doing that. So that day, we have one more visit after this. That day, I was like, all right, let's see what else we can do to improve the lumbar range of motion, the lumbar flexion range of motion without increasing any symptoms. Bilateral.
It was his wedding salon. I know for a fact.
There we go. Yeah. Bilateral sciatic flossing. Made some minimal improvement to that. And then that was like, okay, I don't really think this is what we need to send him home with. We had the discussion at this point because he had mentioned to me, he went out to dinner with one of his friends who's a neurosurgeon that he knows pretty well. And he was like, I'm kind of at the point where I feel like, he said, I don't necessarily want to get surgery because I forgot to mention this. When he came back to me at the beginning of the most recent thing, he said that the surgeon that I had last time said, if I have to have surgery again, it's not going to be good.
That's awesome. That's good bedside manner right there.
And Chad's like, oh, geez. Like the guy's like not, the guy's not I bet you if I'd have met him like 5 or 6 years ago, very relaxed, not as. This is definitely this has worn him down.
Yeah.
He's had to cancel a honeymoon. He's had to. They went on a trip and he like was doing well, slipped on some tile, like landed on his back, and that reproduced all the symptoms again, made it worse.
Sounds like he's clumsy.
Yeah. I don't know.
What if you just told a patient now? You're like, listen.
Yeah.
Like if you'd stop falling down.
He's also like. I'm 27 years old.
Yeah.
Like, I've already had
that way
back surgery and
I've never had back pain until I threw that damn trash can in the dumpster during Farm Fest.
Yeah.
If I had back pain, my back pain wasn't even bad.
Yeah.
It's like sore. If I would have had that when I was 27, I'd be like, dude, this sucks. So to have what he's having, yeah.
Right. And he was, I mean, really good athlete, played soccer,
Yeah.
Likes to be very active and outdoors.
By the way, don't try to like power clean a trash can into a dumpster after drinking all night.
Yeah.
Don't do that.
Yeah.
It's not a good idea.
So,
or do it.
This is, he had the dinner with his friend, the neurosurgeon. And they had kind of talked, and he was like, hey, if you want me to do an MRI or you want me to do anything, I can get you in quicker just because you're like than doing anything else. He mentioned that to me, and I was like, honestly, I don't think that'd be a bad idea. And then we had talked about it, at least getting the MRI to see where he's at now, because we had one, but it was, a year and a half old. So he gets the MRI done. This is November 1st. Reveals extrusion of disc material at L5-S1 with encroachment on S1 nerve root. We had seen, they didn't call it, but you had mentioned when we were looking at it, possible modic changes and vertebral end plate fractures.
They didn't call it, but it ain't one possible. It was happening.
Yeah. But not called an imaging.
Which brings up another point, which I brought up numerous times in previous residencies and talks, like, look at your own images, know how to read an MRI. We have had so much stuff missed, even when it's actually what we're calling on the request to look for. And we're talking minimal stuff, like stuff that any of us would catch, even on x-ray sometimes. So if you don't feel confident in reading MRI, I'm of the stance you shouldn't be getting MRIs on patients, because you just don't know. Like his back, like as soon as I looked at it, I was like, dude, he's having surgery. Like there's just no question.
It was very different than the one that we saw, because we went and looked at the old one too.
Yeah.
He also had.
Sorry to interrupt. Real quick. Do you guys have any resources? Like, I mean, I'm not all the way through school yet, but I feel like as far as MRI goes, I don't feel like very competent in reading that.
Believe it or not, so Alicia and Terry, the Yoakums, they actually teach a decent class, even though it's taught in a state association, continuing ed scenario. So that tends to be looked down upon. Theirs is actually really good. And Alicia teaches it for the most part. Her dad is kind of, giving her the reins. I mean, Alicia's a stud. I went to school with her. You will learn quite a bit in school, but then also, like, I even did an online MRI course for one of the state, the years that I needed 12 CEUs. And I mean, it was well worth it. It was sports focused. But I've also like Rich Holm talks about this all the time, right? He went through a phase where if somebody had an MRI, in particular lumbar spine for him, he put the MRI up, looked at all the findings, then went into palpation and kind of saw or tried to see if there were any correlations with what he saw on palpation to what was seen on the MRI, to see like what are their physical findings that match that. Because that's the big conundrum here, right? Is what's on the image actually presented in physical findings or exam, or vice versa, right? That is very hard to reconcile. What I would say is there's a lot of resources, whether it's reading, looking at images. So I've taken 30 hours of courses outside of what we got taught in school, and I feel like I'm pretty good. And there have been numerous scenarios where we're calling medical radiologists and being like, I think this is here. And they're like, oh yeah, sorry about that. I mean, it's insane. Like we're talking, that's their job. And they miss stuff where you're like, my God. And I don't even think I'm that good. I mean, there's stuff that I've even told these guys, I'm like, I don't know. Like, I'm going to step away from that. Like, I'm not confident. And that's, you also got to know your level. Like, don't just be like, oh yeah, I know. So yeah, get some training if you're going to order them. Otherwise, you're literally just relying on that medical radiologist. So it gets a little, I think, dicey, to be honest with you. So,
and that's kind of the perk of us having 5 people here, is that whenever I do get an image, like you said, you get the report, I want to see it. And then if whatever's called in the report, I don't see it, I'll be like, hey, can you explain to me how that is showing up on here, where you see it?
And like all of us have looked, like Sloan's looked at a lot of different kind of MRIs than I have due to gymnastics. It's just like, we have kind of a learning bubble, which, use us. Like that's one of the, even if you weren't part of this residency, like send somebody that image. We've had numerous times, I can't tell how many times. Sloan was Dr. Kettner's clinician when she was in school. We sent him stuff when we were kind of fresh out of school. And then we became kind of fast friends with the head of radiology for the Andrews clinic here, because he's a trail runner, and we send stuff to him all the time for secondary reads. So I'm not opposed to that at all. And he does that for free, which is a perk, but it's very good to have somebody that's the head of the radiology department for Andrews. We're talking James Andrews, And he's like, yeah, it's not that, or yeah, it's that. And I've been proven wrong a lot of times, and just got to eat your kind of humility at that point.
For any of y'all that intern, for any of the Logan people, if y'all intern at Back Pain Center, Welk's really good too.
Mm-hmm.
And I've sent him stuff, and he does like a lot of things on the side. So he hasn't charged me, but if I do it regularly.
I was going to say, a lot of those guys, like, they're nerds. So if you're asking for their expertise, they want to help you. You know what I mean? Like, just if you guys sent me a hard case, be like, ooh, let me see what I can see. Like, same thing. They want to see those things, like what is going on. Yeah, if you over or abuse it, for sure, it's going to get burnt.
All right. So the rest of that visit, he had said that he has a CT scheduled 2 weeks from then to further investigate the potential fractures, and that he's following up with a neurosurgeon to discuss if they need to do discectomy or lumbar fusion, which he was in much better spirits about the thoughts of having to have surgery compared to before.
Why do you think that is?
I think that because we did the trial of care and he was like, it's not changing.
It's like that was the last.
Yeah. Had we have said that initially, I think he would have been very opposed to it.
Yeah.
But now he said, I'm okay with the surgery. He said, I really don't want to have to have a fusion. You don't drink bourbon. I said it smelled like Sharpie.
Seth smelled like, or said that Daniel got me this bottle of Jack Daniel's bonded Tennessee whiskey, which is really good. But Seth goes, it smells like a Sharpie. Like, he's a true connoisseur.
Lid's still on.
Yeah.
What are you talking about? Blinded by your goggles over there.
Okay. So he was okay with the surgery. He really wants to avoid lumbar fusion.
Yeah.
He can, right? Because he's 28. So this, I hear from him because he comes into the office. I didn't write it down, but he came into the office and told me that he was going to have surgery. He's going to have the microdiscectomy. Ended up having it. We got an email a couple of days ago that he had the surgery on December 1st. Seemed to go well. According to the surgeon, he's had a little bit of nerve pain with certain movements, but all the burning feeling is gone. Just got all the numbness and tingling as well. And 3 weeks ago, he started driving, and going out for longer walks. He's got a follow-up next week, or his first follow-up with the neurosurgeon next week. So I'll get more updates after.
And there's a lot of like what ifs here. Was Chad's strategy of how he stabilized his back crappy? And that's what led to this. I mean, obviously, if you went from kind of normal findings on an MRI to modic change extrusion, like something happened, or was that fall?
Mm-hmm.
So there's a lot of like, I don't know. But it ended up in a scenario where like, dude, this is the best option for you by far.
And I would say his strategy changed because we saw
the intra-abdominal pressure change.
We worked on all that before.
That's a good point.
It was noticeably different after.
And maybe trauma on top of chronic low back pain. And then he goes into this high threshold strategy, and then that's like the kiss of death. And But for 27 years old, the amount of, in my opinion, he had 3 level, like I would say, mild to moderate modic changes.
Yeah.
Which did we ask the radiologist about that?
We did. No, we didn't. We didn't call them.
Okay. I mean, I would 100% say that was the case. I
think that was what we pushed for with the neurosurgeon, though.
Like
to get back
mild bone marrow edema or something. Yeah.
Something like that.
There's something going on there. It almost to the point when I looked at it with Alex, I think it was even like, man, looks like pathological outside of like neuromuscular mechanical stuff. I was like, for 27, that's not, doesn't look normal. So
we'll see how.
It's an MRI. It's an image. You got to match to the person and stuff. But any questions from you guys on Alex's case? And then if not, we can jump into any general Q&A and wrap it up as it's Friday and it's almost 8. Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.